2B internal session of hepatobiliary and GI. We will be recording the session and I will be uploading it on the YouTube. So no worries regarding that. That YouTube recording would be accessible to everyone. So today we have, again, I'm very thankful to all our participants who have volunteered as examiners as well as hot seats. It's never easy. So our first candidate for today's session is Dr. Afshan. Can you see my screen?
Yes, I can see that.
Okay, I'm trying to enlarge it. Let me try. Okay, it's enlarged now, right? Good enough?
Okay. Yeah.
Okay.
Okay.
I will give you the remote control, Dr. Afshan.
Okay.
You can ask for the remote control, but we'll both use it simultaneously. So when I tell you to do not touch the remote, do not touch it. That would be easier rather than taking it back again and to and forth. Okay.
Okay.
Okay. So
Okay.
just request the remote control from me, mouse control, so that we can start the Viva and hopefully it will be as smooth as possible. Okay.
I send you the request.
Yes. Okay. So I'm starting the timer. You'll have 15 minutes and then we will follow it with the feedback. Okay.
Okay.
Take your time. It's just us and no worries. We are here to, all of us are here to make mistakes. No worries. Okay.
Okay.
So this is your first case.
80-year female complained of bilateral chest pain and backache for 1 week after a history of fall down in the bathroom.
Yeah. You can go to the next one. Number 2, you can click 2. Okay, so which one would you like to start first with? Go. I'm giving you this one, axial non-contrast. Yes, go ahead.
This is CT chest. First, I'm scrolling to see all the images. Then I will comment on it.
Mm-hmm.
So in this CT chest non-contrast images, I can see that there is bilateral
Yes.
Not scrolling on my end. Okay. There's bilateral profusion.
Mm-hmm.
More mark on right side.
Mm-hmm.
And
okay, do you want me to scroll for you?
Okay.
Okay. So you want me to scroll these images, the axial non-contrast? Go ahead, give me the findings.
Okay, I can see that there's bilateral profusion and more mark on the right side, and I can see there is some surgery with surgical staple in the cardiac. This is like a cardiac patient, previous cardiac surgery.
Okay.
I cannot see any. Can I see the lung window?
Unfortunately, I don't have any lung windows. What did the patient present with? Do you remember the history?
Have backache and lower backache after fall in the washroom.
So there is a history of trauma, right?
Yeah.
So do you want to see it?
Bone window?
Okay, I'm giving you the bone window. I'm scrolling the bone windows. I'll go slowly, okay?
Okay. I can see that there is fracture on the right side.
Okay.
With likely contusional injury. No, I cannot see any contusion. This is likely profusion. Multiple fractures on the right side, as well as I think this scapular fracture as well.
Okay, so let me stop you here. Okay, there are bilateral rib fractures, but they are non-displaced lower rib fractures, not significant. Is there anything else you can see or there is anything else on these sequences which you want to comment on?
Okay.
Summarize your findings, whatever you have told, tell me.
There's bilateral perfusion, and I cannot see any pneumomediastinum, pneumothorax, as we have seen the. There is NG tube. I think there is some tube or in the distal part of the esophagus.
Okay, ignore that. It is a tablet which is a bit of stuck. Old mama, right? So
Okay,
she has.
okay.
So ignore this. Anything else other than the findings you have told me?
I cannot see any liver injury or splenic injury in these images.
No worries. Okay, we'll go to the next case. Is that okay?
Okay.
So what is your summary and management, and we'll go to the next case.
There is bilateral rift fracture associated with bilateral perfusion mark on right side with some contusional injury in the right lung.
Okay, so how will you manage it? What will you do with the patient?
I will inform my finding to the referring clinician, and this should be managed conservatively. And if the patient has increase in the perfusion can be drained, percutaneously drained.
Okay. This is the next case. No history. This is the ultrasound images. Okay, I'll scroll for you. There are just few images.
Okay. There is in these images, I can see that right kidney is unremarkable, but I can see that there is lesion in the liver. Opposite to the gallbladder, in the around the gallbladder fossa, and it is hypoechoic and almost well defined, and it is not showing any vascularity.
Okay. And what do you think about the liver itself?
Liver appear unremarkable with smooth margins. I cannot see any other lesion. The portal vein adjacent to it appear unremarkable.
Okay, so what is your what are you thinking about, and do you want to do anything next, or is it okay and you'll send the patient home? What is your next step?
I think this is well-defined area around the gallbladder, and this is hypoechoic.
Okay.
And the rest of the liver is smooth and homogeneous in texture. This could be in the is the patient has any specific history, likely pain or fever, so we can think of any developing abscess.
If the patient is asymptomatic, then what will you do?
If the patient is asymptomatic, then
you're happy with the lesion? You're okay with the lesion?
Yes, it is not showing any vascularity, and the patient has normal liver parenchyma. So this can be some liver. We can have CT scan, triple phase CT scan to further evaluation of the lesion.
Okay, I'm giving you non-contrast. Okay, this is first. Okay. What will be your protocoling for this liver lesion?
What will be
your CT protocoling? Your technician will come and ask you, how do you want to do this CT?
Arterial, venous, and delayed phase.
Okay, so this is
images.
I'm going to rush through this. Okay, so this is the plane.
This is okay.
This is the arterial.
Okay.
This is the venous.
Okay.
And this is your delayed. Now talk me through all the phases. What do you see?
Okay, on non-contrast CT, the CT image, this lesion appear hypodense, and on arterial phase, it is showing peripheral arterial puddling, which is following the blood pool. And on venous phase, there is a centripetal fill in contrast, and this is likely to be an hemangioma. which is
Mhm.
showing contrast uptake and retaining the contrast on delayed phase as well. And this is following the blood pool. So
Okay.
this is likely an hemangioma. So I will inform my finding to the referring clinician, and this is likely it is not showing any hemorrhage, or it is very small in size, so it should be followed up. And I will inform my finding to the referring clinician and inform him that this is not subcapsular or large in size, and there is no hemorrhagic density on plain images, so it is unlikely to be a bleeding hemangioma, so it should be managed conservatively.
Okay. Done. This part done. I'm just showing you this slice of the non-contrast CT. Are you okay with how the organs here are?
I'm okay with the
Do you think this is
hear
normal?
you.
This
Okay.
non-contrast, is this okay? Apart from the focal lesion in the liver, does
Okay.
anything else concern you or catch your eyes?
Can you please scroll again?
Yeah, sure.
Little liver is slightly hyper dense.
It is what? Sorry?
Liver is slightly hyperdense.
It's
And
per or po?
hyper.
Yes. Excellent. Why? The reason I'm apologies if it felt offending, but the reason is that when we are in the Viva situation, the examiner should be able to clearly understand what we are saying. So at
Okay.
times this word hyper and hypo gets mixed. That's why so apologies if
Increase
it felt.
attenuation. Okay.
Excellent. So what are you thinking if it's increased attenuation of the liver?
The patient with increased attenuation can be any it can be due to multiple causes.
Right.
Uh, it can be due to, if the patient is taking any medicine, it can be due to metabolic disorder.
Okay.
Um,
So
these
can
are
you give me an
the
example of medicine and any example of metabolic disorder?
metabolic disorder like Gaucher's disease,
Mm-hmm.
and the liver is hyperdense,
Mm-hmm.
and
Okay. So now it's
medicine.
increased density.
Yeah.
What else can you do to help out the clinician?
We compare the density with the spleen and liver, and look for the cardiac area.
Okay, good, very good. That you look for the cardiac area. Why do you want to look for the cardiac area?
uh, to see if the patient has any cardiac problem,
Excellent.
or is for which the patient is taking any amiodarone or something like
Okay, okay,
therapy.
good enough, fair enough. Now I'm on the MRI. Okay, there are multiple images. I'm giving you axial T2 fat sat first. Okay, I'm scrolling
Okay.
from below up.
These
Hmm.
okay. Now the liver appear on T2 weighted images. It appear hypo intense,
Okay,
and the spleen is unremarkable. And I think this can occur in the case of when there is iron deposition, like
excellent.
in hemosiderosis.
Mm-hmm.
I can also see another small lesion in the segment. I think this one in the
Okay,
liver.
okay.
And
What do you think? Can you describe the lesion signal of both as compared to the liver?
it is a light bulb appearance,
Excellent.
like
Okay.
in
Now I'm giving
human.
you, yes, very well done. Now I'm giving you T1 in phase and out phase. Okay.
Okay,
So this is the in phase.
okay.
Why do we do in phase and out phase?
To look for the fat,
Okay. So what do you
microscopic
expect
fat.
in a fatty liver or a fat lesion? What do you expect
It shows a signal dropout
on?
on out of phase images,
Excellent. So what do you have to say about this?
and it is not showing any signal dropout.
Excellent. It's actually showing a paradoxical phenomena, right?
Yeah,
So what do you think is happening?
I think this hypodense, hypointense liver on T2 weighted images with no out of phase dropout is likely due to iron deposition, which
Mhm.
occur in hemosiderosis like thalassemia. And as I can see that a spleen and a pancreas appear is of normal attenuation.
Okay.
Is a normal signal intent.
Okay. So pancreas, what is the significance? If the pancreas is also low, of course, not
Yes.
everything is typical, right?
Yes.
In our everyday life, everything is not textbook, but I'm just asking you a textbook question, huh?
Okay.
If the pancreas is also low intensity, meaning there is iron deposition,
Yes.
so it would go towards what?
It will go towards hemochromatosis.
Which type?
Uh,
It's fine. It's okay. We'll come to it later.
it's pancreatic, I think, manifestation of hemochromatosis.
Mm-hmm.
Um, I don't remember exactly.
Mm-hmm.
I think that is secondary due to rapid transfusion.
Okay. Okay. No worries. Um, we have 20 seconds left.
Okay.
Let me pause. Let me pause for a moment. Let me try to give you a case which would be which would finish quickly. Sorry,
It's
apologies.
okay.
Okay, so this would be your last case, okay?
Okay.
Can you see my screen?
Mm, I think this. Okay. Yes, I can see it now.
But where is it? Okay, let me do it from here. It didn't share. So go ahead. I'll scroll for you. Start describing.
Okay. This is fluoroscopic images of the query, and I can see that there is outbouching noted at the level of the C6 C7, posterior outbouching from the
Okay.
esophagus. And
Spot diagnosis because we are out of time.
this is Zenker diverticulum, and I cannot see any perforation, any retained object in it.
What will you do next?
I will inform my finding to the referring clinician, especially the surgeon,
Uh-huh.
and this should be managed surgically.
Okay. So let's start your feedback, okay?
Okay.
So you can see my screen now? This is
Yes, I can see.
chest pain, okay? So this was basically the history here is coming with a history of trauma, right?
Yes.
And we have seen in our external sessions that exam cases can start like this, that there is history of trauma, right? So
Yes.
you saw the history of trauma, you told me bilateral perfusion, you told me about the rift fractures. Now I told you, okay, there are rift fractures, let's move on. Okay, which is
Okay.
an indication that there is something more than the rift fracture, right?
Okay.
You very rightly pointed out to me that there is this cardiac disease and cardiac intervention, right? There has been evidence of cardiac surgery
Yes.
in this old mama. Now, putting all this together, do you see anything else here?
Yes, now I can see that there is
Yes,
pepper
yes.
dense liver due to a myotron, maybe.
Excellent. Okay, so this is
Yeah.
what happens in a hot seat, and this is what we are here to practice. In routine, we would have almost picked it up always. Okay,
Yeah.
so always in the included, always remember that in chest CT, they will in the included sections, in the lower sections, there can be an adrenal lesion, there could be a pancreatic lesion, there could be a liver lesion, which we are supposed to pick up, right?
Yeah.
So you rightly pointed out there is bilateral perfusion, there is everything. Then you should have said that there is hyperdense liver, which has a number of causes, as you know. But this patient is a cardiac patient as well. So I believe this could be due to amiodarone therapy. And
Okay.
this is
Okay.
it, right? So this was
Okay.
perfect. Next, in I'll give you more causes in the next one. Okay. This one, you see, the reason I was showing, if you, maybe it's not projecting very well on the Zoom, but would you agree with me that this is a sort of coarse ecotexture? It's not a very, it's a sort of bright and coarse. I wouldn't call, and especially when you compare it with the kidney, there is a contrast to it. Okay.
Yes.
I don't know why I'm having a problem with the mouse. Are you holding the mouse?
No, I'm not.
Okay. Then it's on my end. So basically, what you have rightly pointed out, that there is a focal lesion, yes, and the liver is not, it's not normal. It has a coarse sort of ecotexture. And whenever you see this is a hypoechoic area. Either you are thinking that this is a fat sparing area of the liver, that's a totally different scenario. But still, this is not good enough to leave it as such. I understand, because it's near the porta hepatis, it's near the gallbladder, but always do offer that to the examiner that I would proceed further with a triphasic liver CT. Okay. And when you go to the triphasic liver, you rightly pointed out this hemangioma. Okay, this was perfectly described. There was another smaller one, but it was too subtle, so I did not push for it. You rightly pointed out this one, but again, you see, in this non-contrast, this was the same finding which you picked it up, that there is increased intensity of the liver, right?
Okay, yes.
Now, coming to the MRI liver, why was I showed this deliberately to first of all, to show the light bulb sign. We should always say the buzzwords, as you said correctly, in such cases where we can find one. Okay, incidental finding of renal cyst, whatever, there are multiple, at least two lesions seen, which are hyperintense to the liver, parenchyma, and hence the light bulb sign. In the T1 in phase and out phase, as you rightly said, there is no dropout of the signal, which gives the understanding that there is iron deposition, right? Okay. And I would prefer to use the word as hemochromatosis. Okay.
Okay.
Now,
not hemocytosis.
Because hemocytosis would be like due to the multiple transfusions, right? In thalassemia, in iron transfusion. But primary hemochromatosis would be more of a distinct entity. You can, I mean, I also have to read more about it, but that is my understanding. If I'm wrong, I'm sorry, but I think we have to say primary and secondary hemochromatosis. And in secondary hemochromatosis, as you said, in thalassemia and blood transfusions, all these things come out. In the top three differential, which I read before for preparing these cases, there is a mnemonic which makes it very easy. Even, the Prometheus Lionheart uses it in his videos, that P and P, pancreas is P and primary is pancreas, okay? So if the pancreas is involved, it goes towards primary hemochromatosis. And if the spleen is involved, then it is secondary hemochromatosis. So as you said, to rule out splenic involvement is to say that the spleen is not involved is very important. Okay. Then the one I gave you here, you correctly said, and I did rush you through this case because we were short of time, but you correctly said that there is a contrast-filled outpouching from the posterior aspect. Okay. Why saying the posterior aspect is important? Because this one is what you said? Zenker diverticulum. There is another one, Killian-Jamison, right?
Yeah, that
it's
is
usually
laterally.
Excellent, right? So it's good to give more info to the examiner to let him know that you know it. So this is posterior inferior. In contrast, the Killian-Jamison would be anterolateral. This is Zenker's. I would ask if the patient is symptomatic and refer the patient to surgery for further management, right?
Okay.
So these were your cases and very well done. So thank you so much. Is Dr. Nuran, you can go ahead and you will be examining candidate 2.
Yeah, hello.
Hello. Candidate 2, are you ready?
Yes.
Okay, she's ready.
I'm sharing my screen. Just give me a few minutes.
Sure, no problem. We are waiting.
What happened?
No, it takes a bit of time. Last time also it happened. It's okay.
Okay.
We are waiting.
I'm also waiting. I'm not. Well, is there something wrong? Do I need to?
I think last time when we were testing, maybe 30 minutes back. Now it's fine. It's good.
Okay. Is it okay now? Yeah.
Candidate 2, you can see it?
Yes, I can.
Okay, to you guys.
Well, hello,
Okay.
candidate 2. You can
Hello.
start now from the first case, please.
All right. All right. Let me ask for the remote control.
Okay. It's yours.
Oh, thank you.
You may start from the beginning if you want, just to see the, yes.
So, okay, thank you. Can you scroll for me?
Well, you can proceed to
Quite hard for me to scroll.
well, I can't hear you,
Actually,
please.
it's a bit slower on my end.
Nuran, I think you can scroll for her. The speed
Dr.
is a bit
Nuran,
low
it's a
for her.
bit slower on my end.
Okay,
Can you
I'm
please scroll
scrolling.
for me?
I'm scrolling from down to above.
I think.
Is it okay?
All right.
Well, actually, I can't hear you.
Dr. Sabah, there is a very serious lag on your side.
Male. Yeah. Can you hear now? Regarding
Yeah, go ahead.
Sabahat, I am unable to scroll properly.
No,
Okay,
it's okay.
I can scroll, but I can't hear you. Your voice is it's not clear, please.
Is it clear now?
Yes. So this is non-contrast axial. Do you want me to show you the contrast enhanced axial also?
Yes, please.
Okay. Yeah.
Yep.
Yes. Do you remember the presentation of the patient?
Yes, exactly. I remember.
What was
The
it?
patient has presented with diarrhea and weight loss.
And
What
how
I
old is
see
he?
is he was an adult patient of 25 years old.
Lovely.
And I see the prominent mesenteric vessels giving comb sign.
Lovely.
Along
Good.
with that, I see that. Let me see. It is likely sigmoid colon, which was a partly thickened edematous. If I could scroll it well.
Well, I think it's not sigmoid. Just follow it upwards. You can see it is from right,
All right.
lower quadrant. Yeah. I'm going down again.
Okay.
Okay.
Yes, please continue.
So, do you want more sequences?
Yeah, it's a loop of small wall which is slightly thickened and edematous, and it is associated with prominent mesenteric vessels, giving comb signs.
Lovely. So, what's your
also
conclusion?
I noticed that patient is having fatty liver as well, so he must be running some IBD.
Lovely.
I would like to see other associated signs, like there is I want to see gallbladder. Basically, there is to see whether there is any cholelithiasis or not. And also I would like to see both SI joint to rule out ankylosis.
Perfect. I'm going down.
More so, I want to see any skip lesions, if any, but which I couldn't see. So it's an isolated loop of thickened mucosa, which is involving the small bowel. I want to see the ileocecal region. If you could show me, please.
Maybe this is easier to you to see by color.
Yeah,
Yeah.
yeah, you're totally right. It's easier this way.
Okay, what's your conclusion here now?
Yes. No, he is running an IBD, which is limited to the small bowel loop. Likely, it's an ileal loop associated with fatty liver and no other. Yeah, can see the SI joints now. They are fine. So to me, it is likely a case of Crohn's disease, for which I would like to refer this patient for endoscopy and refer it to for a medical physician for further management.
Okay, okay, lovely. It's good. So we can continue.
Yep.
Yeah, this was a Crohn's
Oh,
disease. Yes,
with terminal,
you did well in this case. And yeah, now you can proceed with the second case.
presented with upper GI dates of 50 years male. Okay, thank you.
Okay. I will scroll it again for you.
Yeah, please, thank you. That would be very kind of you. But I'm provided
I will
with
start from above downwards, yeah?
Yep. It's a non-contrast axial CT of patient having oral contrast. What I see is an please scroll, stop scrolling. Is it a swirl sign there of the vessels?
Okay. What do you see
Okay,
here?
what I see there is an edematous thick a loop of, let me see, it's a loop of bowel or it's a mass. Please scroll down. Yeah, please, thank you. Yeah, more, please. Mm-hmm.
This
More,
was
please.
do you want a coronal one?
Yeah, okay.
Maybe more helpful, yes?
Yes. If the patient is having any recent history of surgery?
No.
Okay. Show me axial. I'm fine with them.
Okay, I will go back to axial. So what did you see until
So
now?
it's a heterogeneous mass with the central and ALucencies and some necrosis, and it's filled with oral contrast that we have given the patient. So must be it's in communication with the bowel wall. I am unable to make its connection with the bowel wall, if any. But I am sure it's connected somehow with the bowel wall, or it's.
Is it connected with the bowel wall, or is it just, let me help you.
Bowel itself. It may be bowel itself, but what I'm saying that I am unable to make a connection because I am unable to scroll it properly.
Well, I'm scrolling.
It may be a segment. Yeah, please go down. Please go down. Yeah, please. Yeah, it's a bowel segment. Oh, so yeah, it's a bowel segment which is irregularly thickened and giving mastoid appearance and having a centrifugal sign as well. Plus, I could see that it is having very thin wall on its lateral aspect. It may be perforated at this point, as I cannot see any.
Is there any signs for perforation here?
No, it's a concealed perforation, what I suppose.
Okay.
So I will refer my findings, tell my finding to the referring physician or a surgical team on call, and would arrange emergency surgery for this patient. And later on, that person could attend an oncology MDT.
Okay, what do you think about this? If the surgeon or the clinician, referred clinician ask you about your conclusion or suggestions, what do you think?
To me, it's a malignant lesion, which is having a concealed perforation. That's why I wanted this patient to have an emergency surgery.
Lovely, good. I will extend to the next case. Yeah.
30-year female, all right.
Okay. Well, let me start with the scroll with the axial non-contrast enhanced CT.
Liver is of fine texture. It has smooth borders.
Okay.
What I see is both kidneys are fine.
Well, do you want me to extend to the other contrast enhanced CTs?
Yeah, please.
Maybe it is more helpful.
Portovenous space will be helpful. Yeah.
Okay. So let me go back.
Or okay, what I see there is a peripheral enhancement at certain parts of the liver. Rest of the liver is rather non-enhancing. Yep, and there is a. Can you go up above at the level of hepatic veins once more?
Okay.
It's a delayed, it's a scan which is taken in delayed portovenous phase. I am unable to see for hepatic veins. I suppose they are normal,
It's
but they are
actually
not.
not delayed. This is not delayed, but the other one is delayed. If you
All
want, I
right,
can
the
show you
right
the
hepatic
delayed.
vein is fine, but the left and the middle hepatic vein are non-opacified. They are possibly thrombosed. Yeah, please go down once more so that I can confirm my findings. So sorry. What I said, it was a part of portal vein. It was not hepatic vein. So hepatic veins must be fine. There is a mass at or the lesion at segment 5-6.
Can you
which is
explain this
peripheral
mass, please? The one which
yeah,
is in the screen?
it is slightly irregular, enhancing with central non-enhancing gap. It has it is reaching up to subcapsular region with no capsular retraction.
Okay.
What
good.
I see is what I wanted to see in another lesion, if any. I noticed that there is another lesion of similar intensity in the
Yes,
above
you're right.
segments. Can you scroll above?
Oh, I just
As
missed the
liver
lesion.
margins are yeah. There is another lesion in segment 7, which is not having any central scar like the one in the low
Okay.
inferior one. There is no other lesion as such. Liver is of smooth likely. I will further investigate this patient on MRI liver.
Well, do you need any delayed images for this one? Maybe it will be
that
helpful
would be
for
fine
you.
as well. If you 20-minute delayed images would be helpful if provided. In the delayed scan, the lesion become iso-intense to the liver. However, central scar still didn't enhanced, and the lesion that was in segment 7 severely become iso-intense to the liver.
Sorry.
So to me, the lesion that was in the superior segment is slightly
Okay. You may go. You asked for MRI. You didn't you?
5 and 6 is
Okay. I'll proceed for MRI.
FNH, but I would, yeah.
Okay.
Thank you.
So you said you are thinking of what? Of FNH?
FNH, yes.
Okay. But you want to prove your suggestions by MRI. Okay. This is T1 axial.
I need a delayed T1 post-contrast FAT sequence.
You don't need to check by T2?
Not exactly, but yeah, then the central scar is T2 hyperintense.
Okay.
If it's a primovist MRI, then only delayed scan will help me. T1, yeah, still central scar is not enhancing.
Okay.
Do you have any delayed scan? I think you have.
I think this one is delayed. Maybe.
Yeah, it's starting enhancing a bit.
Yeah, good. Even this, you can see which one.
Yeah,
Yeah.
yeah, yeah. It has shown slight enhancement, means it has taken hepatocyte specific contrast.
Yeah.
That also signify my diagnosis that it is FNH.
Okay, you did very
Okay.
well. So what is your
Thank you.
conclusion? You said it is FNH. So
Yeah.
what is your management in FNH? What do you suggest in your report?
Basically, they hemorrhage very rarely, and there is a very little to no potential of HCC in them. So I will put the patient on surveillance on ultrasound. He can go for surveillance on ultrasound for later in his life, because he's an, I think he was a young patient. No, sorry, it was 50 years old patient. So I would just ask him to do a routine surveillance on ultrasound. That's it. No
Okay.
further scanning is needed.
Do you know any other any complications for FNH?
Yeah, apart from bleeding and
Yeah, it's bleeding or rupture.
Yeah,
You did
bleeding
well.
and rupture.
Yes. Let's proceed to the other case.
Sorry, Dr. Nuran, but 15 minutes are up.
Oh, lovely.
Oh,
Okay.
15 minutes over.
Oh.
Oh my God. It's
Okay.
too short.
Okay,
thank you.
you did very well. I will go to the the last case. You did very well. It was an FNH case with, let me see if it was this. Yeah, this was the case. Well, actually, in FNH, the treatment is conservative, and there is no risk, no malignant potential, but there is just risk of complications like rupture and hemorrhage. And there is some practical points we should keep on them. In cirrhotic liver, whenever we see hypervascular lesion, we should say it is HCC, but you did well because this case has no cirrhotic liver, and usually FNH has no capsule. But if there is a hypervascular liver mass with capsule, we should put HCC in the top of our diagnosis till we prove it FNH. This just for our knowledge, but you did very well and perfect. Regarding the other case, which was the upper gastrointestinal bleeding in 50 years male. Yeah. Well, yes, you are right. It could be a neoplastic lesion, but when you see such an aneurysmal dilatation, which is concerning within a loop, and there is too many mesenteric lymph nodes around it. So extensive lymph nodes and aneurysmal dilatation of the loop, and there is somewhat splenic enlargement, not so big but mild. One should think of lymphoma, small bowel lymphoma, because it is one of the most common tumors. Of course, you did very well by giving metastasis or neoplastic lesions, but these should be kept within the differential diagnosis, which includes inflammatory bowel diseases, adenocarcinoma. But adenocarcinoma usually it is solid lesion. However, there could be a solid lesion in the lymphoma, but it is mostly aneurysmal dilatation because there will be infiltration, tumor infiltration in the muscularis layers of the bowel wall. That's why it is dilated with the extensive mesenteric lymph nodes and sometimes even retroperitoneal lymph nodes with the splenomegaly. So we should think of lymphoma. Also, there is predisposing factors. If you're stuck in the case, you can ask the examiner if the patient has any organ transplant or celiac disease or AIDS, or even if he is Helicobacter pylori positive patient. So these are predisposing factors in lymphoma, which can help you to go straight forward to the diagnosis. But you did well by explaining the findings of the lesion, and even by thinking of metastatic neoplastic lesion. Yes, there is a risk of perforation, but there was no perforation here because you haven't seen any air gas bubbles or any other signs of perforation. So don't put yourself in a critical situation. If you don't see such a, just say it could be a risk of perforation. However, I can't see any free gas or any ascites or free fluid, which can which can make me think of lymphoma. Well, this is your first case. Yes, the age is 25 years, is a young male with diarrhea and weight loss. Yeah, you did very well by, the case is representing the very perfect sign of Crohn's, which is COMP sign, where here we can see the engorgement of perienteric vasculature, which is typical for COMP sign, with the bowel wall thickening. The loop is that in the terminal ileum and pelvic ileal bowel loops are all dilated and thickened, sorry, not dilated, thickened, with engorgement of the perienteric lymph vasculatures, which is COMP sign. This is specific, and you did very well by explaining the other associated pathologies like sacroiliitis, and you look to the liver, because mostly in liver either there is infection or cirrhosis or pericholangitis, even sometimes even hepatic abscesses. You saw some fatty liver, okay, and you did well by looking for the stones in the gallbladder or renal stones, which is mostly oxalate stones. It is well done, very perfect. The management, of course, definitely is steroid or conservative treatment. However, sometimes when there is complications like fistula or abscess, surgery may be helpful for these complications. Other complications of Crohn's disease is strictures, adhesions, and of course bowel obstructions, and as I told you before, fistula and perianal fistula and abscess. You did very well, and your voice is so good, your explanation is good, and you can go straight forward for the diagnosis. You did very well, excellent. Okay, have a good luck.
Thank you so much, Dr. Nuran.
Thank you
Our, the polite and the kind examiner.
Yes. And
Thank you.
and very encouraging as well.
Yes,
Lovely.
yes.
Thank
We
you.
still have time for the exam, so of course we don't have to go hardcore, right?
Right.
Just a few points, if I may add, for
Yeah,
every one of us, right? Because I remember in the hot seat, I was explaining a knee joint, and I said somebody told me that you said frontal chest radiograph of the right knee. This is hot seat. So you should, we should practice that, you know. You don't want to, as Dr. Saneej says, wake up the examiner. We want him to be, you know, happy with what we are saying, using the right words, the light bulb sign, the aneurysmal dilatation. These things keep the examiners, give the impression that you are going in the right track, okay? Similarly, if you're seeing an enhancing lesion in the liver, use the words, I'm seeing an enhancing lesion or a hyper-enhancing lesion in the liver, rather than saying that the liver is not enhancing, right? This is all flow of the hot seat, nothing else, but just for us to, you know. Similarly, for this Crohn's disease, one thing I would add, do say he's a 25-year-old patient, he would need follow-up. So we would let the clinician know that this patient should be followed up with MR enterography rather than CT, because CT would be radiation. We want this patient will be on a lifelong follow-up. So mentioning MR enterography, this would get you points. That I would advise follow-up with MR enterography, right? Similarly, yes, regarding that air thing, that whether you would, if you do not see frank air, as Dr. Nuran was saying, if you want to be on the safe side, you can say, in my routine practice, I would go look at these images in the lung windows, and the examiner will tell you no air. Okay, no perforation. Because if you say that there is air or there is perforation, this would become a critical emergency, right? So the management would go otherwise. So always play on the safe side and non-committal side. So just a few points from my side. Thank you so much, Dr. Nuran, and thank you, candidate 2. Let's go to Dr. Awadh, and
Well,
volunteer.
I'll stop sharing, isn't it?
Exactly. Yes, Dr. Nuran. Thank
Okay.
you so much.
Lovely. Thank
And
you, too.
Nikhil, you'll be the hot seat.
Yes.
Yes,
You
Dr.
can hear
Awadh.
me?
Yes, we can hear you loud and clear. You can share your screen. Dr. Nikhil, you are there?
Yeah, am I audible?
Yes, you are audible. Perfect. Okay, to you guys.
Heard?
Yes, go ahead.
Okay.
Shall I start?
Okay, you can start. Dr. Nikhil.
This is a 40-year-old male patient with vague chronic abdominal pain.
Yes. You want? I will give you the mouse control. Okay. Here you are. You can start scrolling.
These are contrast enhanced images of CT abdomen, coronal reformated images. Shall I scroll?
Yes, you can. You have the control actually.
Scrolling is a bit slow.
You can scroll by wheel or
Yeah, it is going. It is happening. So I'm viewing at the soft tissue window. There is a, I think there is a mass lesion in the central abdomen in the mesentery, which
yes.
has central calcification, and the margins are irregular and speculated. There are radiating strands into the adjacent mesentery, and prominent vessels are seen. There is tethering of the adjacent bowel loops, and some wall thickening is also seen in the adjacent bowel loops. This is suggestive of desmoplastic reaction within
Yes.
the region. I will see rest of the images.
Yes.
These findings are highly suggestive of a carcinoid tumor, and
Okay.
I'm looking if there is any primary lesion seen within the bowel wall. And I also want to see any lesion in the liver.
Yes.
It can spread to the liver. Trying to spread. We will inform these findings immediately to the referring physician and also refer this case to the gastrointestinal MDT.
Yes.
And I will also suggest an octreotide scan to look for any spread of the lesion anywhere else in the body.
Perfect.
I think in these images I can't see any obvious lesion in the liver.
Yes.
I will
Correct.
see all the images. And I would also like to see the lung window and bone window.
Perfect. So what is the final diagnosis?
So my final diagnosis is a carcinoid, a small bowel carcinoid with desmoplastic reaction.
Yes, perfect. Okay. Let me ask you one question. You do well in this case. What's carcinoid syndrome? Do you know?
Carcinoid syndrome, it is characterized by the symptoms which is caused by excessive secretion of the serotonin and histamine, and it usually happens when there is spread of the carcinoid to liver, because if it has not reached the liver, these chemicals will be metabolized by liver, so carcinoid syndrome will not happen. But once this is spread to the liver, these bypass the liver metabolism and cause symptoms like diarrhea, headache, flushing, which is a part of carcinoid syndrome.
Perfect.
Next case is a 75-year-old male patient with acute abdominal pain, no previous abdominal surgery. This is a frontal radiograph of the abdomen. It shows a few dilated bowel loops. I can see air on both the sides of the bowel wall in this, but I think it is because there are two adjacent bowel loops by the side of each other. So this here is another dilated bowel loop. Here I can't see any air outside the bowel, and so this is acute abdominal pain. This might be a bowel obstruction, likely a small bowel obstruction. There is suspicious lucency in this region, which represents the area of the portal vein.
Okay, ignore it.
Okay. And otherwise, I can't see any bowel wall thickening or intramural gas. I can't see any obvious signs of pneumoperitoneum. There is no free gas under diaphragm. I am looking at the hernial sites. I can't see any hernia,
Perfect.
obstructed hernia, and I can't see any stone, a gallstone. So I will immediately pick up the phone and inform the findings to the referring physician and ask for urgent surgical referral. I would also, if the patient is clinically or the clinical status of the patient allows, we will go for a CCT abdomen on an urgent basis to find out the cause of the findings.
Perfect. So what's the common cause of a small bowel obstruction?
Usually, if he has a history of surgery, there it will be due to any
There is no
adhesions.
history of surgery.
But there is no history in this case. If it is an adult patient, it may be due to any malignancy.
Yes.
Or any gallstones or strictures.
Yes. Here, this is the CT of the same patient.
This is contrast and CT axial sections.
I think still you have the mouse control. You can scroll.
Okay. I'll start from the top, from cranial direction. There are multiple dilated bowel loops. I would also see the lung window. There is mild left-sided pleural effusion.
Yes.
There is a linear opacity in the region of pancreatic tail and some hypodensity seen in the pancreatic body. This
Carry on. Continue scrolling.
I'm trying to scrub, but there are multiple fluid-filled dilated bowel loops. There is some bowel wall, irregular circumferential wall thickening in this region.
Just this bite of pyrrhus. Continue scrolling. This may be a non-distinction. Ignore it. Okay.
In the caudal direction.
Yes. Continue.
Find out if there is any abnormal deviation. There is a fat seen within the bowel loop, so this is an intercession.
Yes.
In the one of the bowel loop in the pelvis shows intersusception.
Yes.
I would like to see the other images also to look for the location or level of intersusception, whether it is ilio-ileal or iliopolic.
So you can change to the corona if you want.
I'm sorry, there is some lag.
I will scroll for you. Let me scroll for you.
This is the area of intersusception.
Yes.
This is the segment of the bowel. I think this is a small bowel, maybe ileum, and I would like to find out the lead point for this intersusception.
Yes. Great.
I'm not sure, but there is some wall thickening here which may be a lesion.
Okay, what else? What else you can?
I would see the lung window to rule out any free gas in the abdomen.
No free air, okay. What else here?
The aorta is there is aneurysmal dilatation of the aorta in the abdominal mid-abdominal section, the lower, some
So-
sclerotic calcification.
So final diagnosis?
So this is a small bowel obstruction due to intersusception,
Yes.
probably in the ileum,
I can't hear you well.
and I will immediately inform the findings to the. Hello?
Okay. Okay. Perfect. Awesome. Next case.
This is a 45-year-old female patient, which she has 3-day history of central abdominal pain.
You want to scroll?
Yeah, I will try. These are axial sections of CT abdomen with oral contrast and venous face. I'm trying to scroll the images. So it is what happening for me.
You want me to scroll for you? Let me
Yeah,
see.
yeah. Yes.
From up down.
Yeah. You can see the lever appears normal in the density, no focal lesions. In appears normal. Opacified ball looks appear normal. There is no wall thickening. Kidneys show normal parenchymal enhancement. There is a segment of bowel loop, small bowel loop, which shows circumferential in what this one. There is circumferential wall thickening and narrowing of the lumen in this region.
Yes.
It is, I think it's a long segment
Yes.
involvement. There is some fat stranding adjacent to this segment. The
Yes.
oral contrast is seen crossing through the narrowed lumen into the distal segment. There are no signs of obstruction proximal to it.
Perfect.
There is no free fluid in the abdomen. No obvious enlarged lymph nodes are seen. There is no calcification. I would like to see the lower abdomen also. There are some clips in the GB fossa.
Yes, there is history of course. Okay.
So I will inform the findings to the referring physician and ask relevant clinical history, and I will also review any old images for comparison. So this
Central
is
abdominal pain. No other history apart from previous cholecystectomy. This is the corona may be helpful also. This is the portovenous phase. Keep in mind. So you describe this well. There is a
yes.
long segment of small bowel thickening surrounding the house. What
Some
possible cause?
fats. So this female first diagnosis that I will put is Crohn's disease, and the other differential can be any inflammatory disorder like tuberculosis.
No,
I would like to confirm this.
Can you look again to this corona? What else the possibility? Keep on thinking on the differential diagnosis.
There is neoplastic lesions. It can be lymphoma or carcinoma, but lymphoma will cause aneurysmal dilatation. Carcinoma will be associated with adjacent lymph nodes, local lymph nodes.
What else other than neoplastic and inflammatory?
This is circumferential and small. They involve the small ball. So I think this should be inflammatory.
Okay, let us go to the next case. No.
Dr. Awadh, we are left with 14 seconds. So you'll have to hurry it up.
Okay. You can take this case quickly.
Okay. This is a 30-year-old female patient with constipation, nausea, vomiting for 7 days, and colicky epigastric pain for 3 days. This is a frontal radiograph of the abdomen. Patient is slightly tilted. There is a abnormal opacity in the near the midline in the central part of the abdomen. I will rule out an history of foreign body, any relevant history related to this. Otherwise, just a few gas-filled volumes are seen, but these are not dilated. I will discuss this case with the referring physician. More.
So, what is your conclusion? What this could be? Give me. Or what one?
I would also like to see a lateral view if available. This could be a foreign body in the signal column.
Yes. Okay. Great. If you do you want to know any history or what type of foreign body?
I'm not sure actually. This rectal inserted.
What? I can't hear you.
I'm not sure what kind of foreign body it is, but maybe this is any rectal inserted device.
No such history. But good thinking.
But I'm sorry.
Let me help you. There is a history of endoscopy before. Okay, you do it. What other differential diagnosis could be?
For this, I'm sorry. Actually,
Okay, great. You do well in all of the cases. Let us start by this case. If you will describe it as you described, there is a radiodense foreign body in the right lower abdomen. Then you can ask for the history. In the last minute, I tell you there is a history of endoscopy. There is history of gastric balloon for weight reduction. So this is migrated, yes, deflated balloon as a cause of small bowel obstruction. But you can put the differential diagnosis, as you mentioned, rectal foreign body, or could be gauzy biboma, for example, if there is previous history of abdominal surgery, but there would be multiple gases. Okay, here this is the CT, not time to show it. Here, this is the valve of the balloon which migrated and caused small bowel obstruction. The stomach is empty. There is a history of bariatric surgery or bariatric reduction for which endoscopic balloon gastric done. And later on, this was deflated and migrated as a cause. Okay, let's check the other case. This case, you describe the differential diagnosis well. There is long segment of structure and smooth neural wall thickening, no bowel obstruction, no free air, and there is a cholecystectomy clip. But check the causes, as you mentioned, inflammatory, neoplastic, infectious, also vascular or ischemic. So you want, this is a portovenous phase. Check the superior mesenteric vein. Let me show you. Here, you see, maybe not projecting well in the zoom. There is thrombus non-enhancing of the superior mesenteric vein. while the splenic and the portal are well enhancing. Also, there is a THA phenomena or transient hepatic attenuation due to compromised portal flow to the liver by superior mesenteric vein. So this is a venous mesenteric ischemia. Okay. What you describe and the differential diagnosis is great and wise. Here, this is the annotated image, the lung segment, the surrounding mesentery, and the thrombus within the superior mesenteric vein. This is the THA phenomenon. In this case, acute abdominal pain, you did well, very well in this. No more to add. There is a small bowel obstruction, dilated centrally located, evidenced by their valvular convensy. Your birth negative, no free air, no pneumobilia or portal venous gas, no pathologic calcification. Also, you check the hernial orifices, perfect, you do well. In the area, there are multiple fluid levels. In giving you the CT, you describe it well. The free fluid, the effusion, the nasogastric tube, and the intersusception segment, ilioaerial. This is fair enough, actually, as you mentioned, in adult must be a cause as lipoma, Nikhil, lymphoma, GIST, for example, or adenoma. This was operatively done. There is a small GIST, maybe this, but enough to say there is a ilioaerial intersusception as a cause of small bowel obstruction. This is enough to proceed for surgery, and no free air, no intramural air. You do it well, perfect. The other case, I think, and this also you do it well. No more add to this one. The birth negative you mentioned, no hypervascular meds in the liver, no small bowel obstruction, no free air, no free fluid. And also you will check the bone window and your recommendation to MIBG scan or ectonucleotide or dotatate scan, whatever you want to check the liver. So perfect, you do well. Thank you.
Thank you.
Thank you, Dr. Awadh and Dr. Nikhil. Thank you so much. Next would be candidate 4. She would be examined by Dr. Saneej. Dr. Saneej, you can share the screen.
Okay.
Okay.
Yeah, good evening, Dr. Saneej.
So you are candidate 4?
Yeah, good evening. Can you hear me?
Yeah, I can hear you. Well.
Okay, so 70 years old female patient with abdominal pain. So I'm provided with a frontal radiograph of abdomen of a 70 years old female patient with abdominal pain. So in the visualized lower chest, I see some post-surgical clips in the midline. And there are few prominent small bowel loops seen in the abdomen. I don't see any obvious free air in the abdomen. No abnormal calcific opacity noted. I see one linear calcific shadow here, but I don't think that's a surgical clip or something.
Ignore it. Ignore it.
Projection something.
Ignore it.
Yeah. And there is a lucency projecting over the right iliac bone. So, but that is in the confines of properitoneal fat line.
Ignore it.
Yeah, so, and I'm trying to look at the any other obvious?
Is having left upper quadrant slight pain and discomfort.
Okay. Left upper quadrant pain. So I'm having a look at the left upper quadrant. I see this some air in the left upper quadrant. I am not sure whether this is intraluminal or extraluminal. Maybe this is between.
That is a lung. That is a posterior part of the lung that is seen.
Okay. Yeah. So
There will be some lung infradiaphragmatically posteriorly.
yeah. So I don't see any abnormal air fluid levels. Left only this prominent loop of bowel I am seeing here.
What will you see in the left upper quadrant normally?
Normally we see spleen, but I don't see splenic shadow project, as there is a bowel loop seen here just beneath the
You
diaphragm.
cannot see spleen always. Maybe it will be obscured by colon or something. Otherwise, what bowel gas shadows we will see in the left upper quadrant?
Otherwise, we see the splenic flexure, we see the stomach,
Where are those? Where are those?
So this is the small bowel, what we are seeing here. And I don't see the stomach fundus bubble. I don't see that.
Can you look for that? Can you just see whether can you see any stomach bubble, stomach gas shadow, fundal gas shadow?
I don't see it beneath the left dome of diaphragm.
Okay.
So maybe if there is a gastric pull through surgery.
No surgery.
No surgery. No surgery. Okay. Then if there is a case of gastric volvulus or something, and stomach is at maybe herniated.
So don't put you in trouble.
Because I don't see the gastric fundus shadow.
Okay. So what will you do?
As the patient has left-sided abdominal pain, I would do a CT scan for further evaluation and to look for the cause of the pain. As I'm not able to ascertain. Okay, I see some bowel loops. These are the bowel loops projecting in the pelvis.
Yeah, that's normal colonic bowel loops.
Yeah.
This patient had. It's not that patient, but consider this as the same patient. This patient had a barium examination.
Okay. Okay, so in this patient, I see this is a barium meal follow-through study, and the stomach is opacified with contrast. And then I see the C loop of the duodenum and the jejunal loops. And they are all to the one side. They're all located on the left side, these jejunal loops as well as the stomach. But the stomach appears to be irregular in outline. The mucosal fold, mild mucosal fold irregularity, as well as it is, okay, I see this part of stomach is contracted.
Which part?
It's like pylorus. Fundus, this is like fundus body, so pylorus and pyloric antrum, it appears small and contracted in size. So this could be related to, and there is some mucosal irregularity also. This could be related to some inflammatory or malignancy related cause, which is causing luminal narrowing, and that's why I'm not seeing contrast opacification on this part of the stomach.
Yeah, you can describe which part, because you don't have the pointer.
Okay, so I thought I'm using a pointer, that's why I'm continuously moving it. Sorry, I didn't realize that.
No, you are not given a pointer, so you can describe with your words.
Okay, so
someone is sleeping, they can someone is closing their eyes can also visualize what you're saying.
So fundus and body appear to be normal. Normal in the sense they are distended, but there is some mucosal irregularity. But the antrum and pylorus region are narrow.
Hmm.
So that is the regional abnormality which I am seeing. So so I think there is to be some inflammatory or neoplastic cause which is related to that, or there is some.
What will you select? Is it inflammatory or neoplastic? What will you select first?
First, I will select neoplastic.
Okay, why?
First, it is an elderly person,
Hmm.
and another, it is an irregular narrowing.
Hmm.
Yeah. So,
And is there any other signs that you can see that is favoring a mass?
mass like a shouldering, I am seeing.
Okay.
Yeah, some shouldering, I can say some shouldering and irregularity between the distended and the.
Is this some shouldering? Is there is shouldering?
There is shouldering. There is shouldering. Yes.
Okay.
Yeah,
Okay.
there is shouldering. There is mucosal irregularity, and the non-distended part also appears quite irregular in
So is it
outcome.
a short segment or a long segment?
So it is not a short segment.
That
It's not.
means
A short segment generally means malignant, and a long segment means inflammatory or
is
inflammatory.
that true always?
Thinking not true always. Not
Okay.
true always. And this is not very long, and this is not very short also. So, but yes, I am first possibility. I'm thinking in terms of neoplastic, and
So
second
if
in
it is a long segment neoplastic lesion, is there any something
that is
specific name?
linitis plastica. A
Okay.
long segment neoplastic is linitis plastica, which could be related to any breast cancer or lung cancer metastasis also.
Hmm.
Otherwise, long segment could be lymphoma, but that is very smooth
Okay.
thickening with aneurysmal dilatation of the bowel. And
So what will you do?
so I will suggest an endoscopic correlation
Hmm.
for this patient, and
Hmm.
endoscopic biopsy. And for staging, I will do CT chest, abdomen, and pelvis to look for
Okay.
lymph nodes, ascites, and any extra.
So these are some selected sections. Okay, you can describe this.
So in the selected CT abdomen with contrast study sections, there's a
Hmm.
coronal images. I
Hmm.
see there is uh, I can appreciate linitis plastica
Hmm.
like with diffuse luminal narrowing and wall thickening. So
Hmm.
I cannot appreciate any lumen in this, which is
Okay.
extending. Yeah.
So what will you do?
So as I said, I will discuss my findings with the referring clinician,
Hmm.
and a CT. I will suggest a CT chest, abdomen, and pelvis for staging, and an
Hmm.
endoscopy evaluation with a
Hmm.
discussion in GI MDT is recommended.
Okay.
Long-standing abdominal discomfort. On examination, he was found to have a large abdominal mass, 55 to 60-year-old male.
Okay. So I will scroll for you. You can
Yeah,
see.
thank you. So this is a patient of 55 to 60-year-old male patient with a large abdominal mass. So the visualized liver and spleen are normal in attenuation. I mean, rather liver appears a bit fatty in attenuation.
You can say when to stop and when to scroll upward and all. Okay.
Now I am seeing the pancreas is atrophic, and there is a large mass lesion, a large cystic mass lesion, which is lying in relation to the uh, it's like posteriorly it is abutting the pancreas, and anteriorly it is abutting the anterior abdominal wall. This lesion has got thick irregular peripherally enhancing walls with some internal septation, and so if as the pancreas is shrunken, so I think this patient might have had a history of pancreatitis, and this could be a pseudopancreatic cyst which has developed over a period of time and
History of,
is
no history of pancreatitis.
okay. So as there is no history of pancreatitis, and so I'm excluding the possibility of pseudopancreatic cyst. So this could be a mesenteric lesion, a mesenteric mass, a mesenteric tumor, like a mesenteric lymphangioma.
How will you differentiate it from a pancreatic lesion? Is there any sign? Can you see here?
So the communication with pancreatic duct
Is there any communication?
I don't see. If you can please show me again. Yeah.
What is this? What is this?
So this is pancreas. So this is pancreatic parenchyma.
This is parenchyma.
And this is fat.
Okay.
Yeah. So I see fat between the lesion and the pancreas.
Okay.
Yeah. So there is a fat plane between the lesion and the pancreas.
So are you still?
No, I'm not actually. I don't think it's arising from pancreas.
Okay.
Yeah. I think it's a mesenteric lesion, and it's lying in close relation to the bowel also anteriorly.
Which bowel?
And that's a small bowel. I think I would like to see it again. Yeah. This. Okay. That is stomach. So it's
Okay.
basically in the region of lesser sac. So because anteriorly it is stomach and posteriorly it is pancreas.
Okay.
Yeah. So it's like a basically more of a cystic lesion with thick enhancing irregular wall peripherally. So this could be either infective or inflammatory,
Hmm.
or this could be a lymphangioma, or even a hydrated cyst in the mesentery.
Hmm.
So I would.
Are you considering it from a mesentery or is it from a
No,
bowel loop?
this no. Mm,
Do you want to
from,
see the coronal?
from yeah, I would want to see cornea. Yes.
Okay. So which is the origin, like from where it is originating?
I think stomach.
Okay. So
it could be a gist.
okay.
It could be an extraluminal gist, or I mean, it's lying in. I can very well see it. The fat plane with the stomach is lost, so it is arising from the gist, and could be a gastric duplication cyst, or could be a gist.
Oh, which one? Is it a gastric duplication cyst or a gist?
More likely gist.
Okay.
Yeah. So I would discuss my findings with the referring clinician, and this patient needs a gastroenterology referral. And further evaluation, patient can a histopathological correlation would be needed, or for confirmation of the diagnosis.
Okay.
Yeah. Suspicious lesion on ultrasound in a 45-year-old female. So
I think okay. Okay.
this
I
is
think
a
this case has been seen, but you can describe.
seen. Okay. CT. So as the patient had a suspicious lesion on ultrasound, so a CT scan was done. So
This is liver lesion on ultrasound. Okay.
Okay. So axial CT abdomen images without contrast. So I saw a hypodense lesion in the liver in the right lobe. This is a moderate size hypodense lesion in the right lobe, and this appears mildly irregular in outline, though I would want to see the contrast study. And I see another lesion.
So which phase you need?
Which phase is this?
This plane?
Yeah, this appears to be a plane study.
Yeah, which phase of contrast you need?
So I would need arterial, portal venous, and delayed triple phase study for establishing, for characterization of lesion. So this is the arterial phase. So I see there is peripheral. I saw some peripheral nodular, enhancement in the larger size lesion as well as in the smaller size lesion. So, okay, there are multiple lesions actually. And most of these lesions are showing similar enhancement characteristics. So I would like to see the portal venous phase to look for centripetal filling in of contrast, which I am appreciating on this phase. So on the delayed, I would like to see if it becomes isoattenuating to the rest of the liver parenchyma, which is becoming. So I'm thinking. So this is a hemangioma. Actually, there's a multiple liver hemangioma. So I will convey my findings to the referring clinician, as these are benign lesions. Just the only complication which can happen with them is hemorrhage. So there is a risk of hemorrhage associated with this when they get giant sized, large size hemangiomas. Otherwise, they are a benign lesion and they can be just followed up on ultrasound.
Dr. Saneej, sorry to interrupt. The time is up.
Okay, I think is it the last candidate or is there anyone else?
Not really. I can fill in for the one who was not able to, as you wish. No, we have an extra seat, but the candidate is not here, so I was planning to fill in for her, as you wish.
You are going to be the next what's it?
Yeah, I can be.
Okay. 1 second. Let me smoke the. Okay. Sabahat, then can we continue this or do we?
Yeah. Go ahead. Continue it. No problem.
Means no. Okay, we'll see the previous thing. You can take this case also, like final.
Me?
Yeah.
Okay, so I'm presented with a frontal chest radiograph of a skeletally mature patient. So I'm having a look at bilateral lung fields, which do not show any obvious abnormality. The cardiomediastinal silhouette appears to be normal, just mild prominence of pulmonary bay, and the visualized bones, bilateral clavicles, shoulder joints, and the vertebrae appear to be normal. There's no evidence of free air under the domes of diaphragm. So, and the fundus gas bubble is also seen beneath the left dome of diaphragm.
So you are always looking at the fundal gas now onwards. Okay.
So I don't see any evidence of any. I mean, can I know the history of the patient?
Patient presented with abdominal pain.
Okay. So I don't know if I'm overcalling, but if there's some calcific opacity seen in the right side of the abdomen.
Yes.
Yeah, because very faintly
Patient presented with the right side abdominal pain.
Because very faintly I can see some calcific opacities in the right side, towards the edge of the film, almost towards the edge of the film. So which could represent either hepatic calcifications or in a lesion within a liver. Within liver, it could be hepatic calcifications, or if I can see a complete radiograph of abdomen, I can be more sure if it is not related to kidneys.
I don't have a complete radiograph of abdomen. So what are your differentials?
Could be related to kidney, could be related to liver.
So what are your differentials?
So if it is related to kidney, if it is related to liver, it could be a granulomatous lesion, a calcified lesion. But as patient is presented with abdominal pain, so that lesion is less likely to cause any pain. So I'm thinking if what other lesion can cause calcification, even a old calcified hydrated would be there again, that would not cause pain. But then
so what will you do?
So I would want to do further imaging of the patient with CT scan.
Okay.
Okay, this looks like a calcified hydrated. Yeah, within the.
Why you are thinking it's an hydrated?
Because of the floating membrane kind of appearance within the lesion. Yeah.
Okay, we'll stop here. So candidate number 4, you know everything, but you are saying only when you are asked, like all the buzzwords, all
Okay.
the findings,
Yeah.
you need prompting and you need a lot of prompting and asking. Then only you are saying you know everything.
Okay.
But in the real exam, because now today what I did was I was very kind and very prompting. So
Yeah.
real examiners are not like that. Like they won't give you this much details, this much in detail. They will not prompt you.
Yeah.
So you have to make them somnolescent, like by just like singing a song or something. Like you have to make them asleep by saying everything
Yeah.
by your own. Okay.
Yeah.
So this is a hydrated cyst, like the typical sign that you told.
Yeah.
What is that sign?
Floating membrane.
Floating membrane sign. Yeah. Okay, that you have to tell. And when you have shown that X-ray, that you correctly picked up that calcification, and you have to tell the differential. Like it can be from the liver, it can be from the kidney, and you have to tell all the DDs. Before asking, you have to tell the DDs and all.
Yeah.
So this one was well done. Like was a simple case, typical hemangioma with peripheral nodular enhancement with centripetal filling, and you have asked correctly that arterial portal delayed and all, and your findings are good, and your management also good. And this one, long-standing abdominal discomfort on examination is found to have a large abdominal mass. Here, before going to jump on sort of pancreatic cyst, you can just say that if this patient had history of pancreatitis, then I would think the possibility of like that you can tell. But you directly went on to say that the pancreas is atrophic, so that I am thinking the possibility of pancreatic pseudocyst, and I had to show you the fat plane and all. So that will be the correct approach. Then the examiner will tell you that there is no pancreatic pseudocyst. And here also I have to push you very much, like to see the organ of origin, to look at the stomach and the indentation on the stomach and the loss of fat plane on the stomach. All these things you told only after when I pointed out. And again, and even after that, you were in doubt like whether it's a gastric duplication cyst. So it's a typical appearance of a gastrointestinal stromal tumor. Okay, so nothing. I think otherwise it was fine. And you have to check for any lymph node enlargement. Usually there won't be any lymph node enlargement. So it's actually a submucosal lesion arising from the stomach. It's a cystic gist. And this one actually here you can see the stomach wall. There is some diffuse thickening here. So that is a finding here. Actually, it's very difficult to see in the first instance. That's why the examiner may help you by saying that this patient is having some right or left upper quadrant discomfort and all. So you can see the transverse colon, splenic flexure and all. But obviously, spleen may not be seen always. But fundal gas shadow, you had to say that I'm not seeing any obvious fundal gas shadow, and you are going to volvulus and all. So be careful. It's not patient is not presenting acutely and all. So there is some nodular thickening, diffuse gastric wall thickening. So you can tell the differentials, like it can be linitis plastica, it can be lymphoma, and then they may give you a barium. So in this barium, you have to correctly describe that there is some diffuse luminal narrowing, diffuse wall thickening, and some mucosal irregularity, and there is shouldering. So I have to push you to say that to say this shouldering. So this is some typical of malignancy. So it's a long segment mucosal irregularity and luminal narrowing. So typical of linitis plastica. Okay. So you can tell the differential of lymphoma, but it's unlikely. but more towards an adenocarcinoma. And you correctly told it can be metastasis, can be a primary adenocarcinoma.
Yeah.
Okay.
Okay. Thank you so much.
Dr. Saneej, we have 20 minutes left. So should I make the hot seat as 10 minutes so as to leave the time?
No worries. You can make it 15 minutes. We can have a 5 minutes discussion.
Okay. Okay.
So you are in the hot seat, right?
Yeah, I'm in the hot seat.
Okay. So I have to select some difficult questions.
Don't worry, hot seat will even make simple cases hard.
Okay.
Okay. Should I request the mouse control or?
No. I'll give you my.
Okay. Okay. So I'm starting the timer. So
Yes.
these are images from an MRCP, which demonstrates dilatation of the intra and extrahepatic biliary channels. I do see a paucity of the biliary channels at the expected level of central hepatic ducts. I do not see any filling defects within the gallbladder. I'm trying to see trace the common bile duct, the extrahepatic biliary duct, as well as the pancreatic duct. I cannot see it actually in these images. In my routine practice, I will also look at the source images, the T2, T1, and the post-contrast. So here are the T2 images of the MRI abdomen in this patient.
So it's a static image.
Oh, okay, it's a static image. It does show, again, the dilatation of the intra and extrahepatic ducts. And there seems to be sort of, this is out of phase image. There seems to be a sort of ill-defined lesion at the level of expected level of conference, I believe.
So this is a contrast. Can you see any enhancement or enhancement?
No. Actually, no. I do not see any contrast enhancement of any suspected lesion, which I was thinking on the previous images.
There is no mass. There is no mass. Okay.
There is no mass. So now I'm wondering that what can be the reason of such biliary channel dilatation. So one reason could be a primary sclerosing cholangitis, or the recurrent hepatic cholangitis, or pyogenic. I would discuss with the physician regarding if this patient has history of inflammatory bowel disease, such as ulcerative colitis.
This patient had a history of ulcerative colitis.
Okay, so if this patient has history of ulcerative colitis, then it more goes with the diagnosis of primary sclerosing cholangitis. And I would inform the clinician, involve the GI team, and the patient would be referred for the first line of treatment would be to relieve his biliary duct dilatation, and an interventional radiologist and a GI team would be involved in the management. So this is a 60-year-old male with excessive alcohol intake and abdominal pain.
So I am giving you remote control. You can.
Okay. So right now, okay. I'm scrolling, right?
Yeah.
Okay. So these are axial images, non-contrast CT abdomen. I'm scrolling craniocaudally. So I can see a few atelectatic changes in the lung basis coming down to the liver and at the level of the spleen. I can see that the pancreas is, there is extensive peripancreatic fat stranding. The lobulation, the pancreatic parenchyma borders are irregular. This parenchymal stranding is actually also extending below to the proximal root of the mesentery. I would like to take this case further with contrast enhanced images.
Yeah, please, you can take.
So I'm taking first the arterial phase because it has been provided here. So with this extensive fat stranding around the pancreas with history of excessive alcohol intake, I have the provisional differential of pancreatitis in my mind. I'm going to look for its complications as well. So I'm going to carefully look in the arterial phase at the splenic artery to see if there is any pseudoaneurysms or any bleed from the pseudoaneurysm. What I can see is at the distal end of the splenic artery, I can see an outpouching. So this seems to be a splenic artery pseudoaneurysm. However, I do not see any extensive contrast bleed. Going to the portovenous phase. In the portovenous phase, I'll be concerned regarding the, sorry, there seems to be a bit of lag, but let me go up and then I'll come down. Okay, it's going the other way around, it seems. So there is extensive peripancreatic fat stranding, as I mentioned before. I'm trying to come to the level of the splenic vein and the superior mesenteric vein. I'm also looking at the spleen parenchyma itself to rule out any complication of splenic infarct. So the splenic vein and the superior mesenteric vein are patent, no thrombosis. There is extensive fat stranding. However, I do not see any fluid collection. I do not see any area of necrosis within the.
Okay, this patient had a CT after 1 week, and there was a fluid collection very related to the pancreas. So, what is your diagnosis then?
1 week after, right?
Yeah.
1 week after. So this is peripancreatic collection. If it would have been after 4 weeks, I would call it pseudocyst.
Okay, you can leave the mouse now.
Yeah, I have. So this is 40-year-old female, 2 days of abdominal pain, tender across the lower abdomen with wakefulness. Okay, so this is a 40-year-old female who has come with vague abdominal pain. And in the frontal radiograph of the abdomen, I can see a distended, hollow, gas-filled structure, which is, the major part is lying to the left of the midline. I can see the hostry. I can also see the dilated small bowel loops. I do not see any dilated large bowel. I do not see any pneumatosis coli. I do not see any free air or air in the portal vein. This is a 40-year-old female patient. However, considering the distended hostral viscous, I would keep the cecal volvulus as my prime differential and immediately contact the surgeon on call and inform him of my diagnosis for the management.
So the surgeon is on your phone, and surgeon is asking you like whether it's a sigmoid or cecal volvulus, because
the management will be different.
Yeah, what will you say? Yeah, he want to make sure that it is sigmoid or cecal. What will you say?
Okay, I would say no, this is cecal, because if it would have been a sigmoid volvulus, it would have been ahostral. I would have typically seen a U-shaped loop. The apex would have been towards the left hypochondrium, and I would not have seen the dilated large bowel loop, small bowel loop, sorry. The small bowel loops would have been collapsed. But the fact that this is also causing dilatation of the small bowel loops, and there is hostra, so this is a cecal volvulus. However, the clinician made me do the CT scan. So
I given you the
okay. So I have the CT scan axial images, and these are the portovenous phase. So I'm going craniocaudally. The liver is fine, and I can see a distended gas-filled as well as fecal-filled structure, which is on the major part is on the left side of the abdomen. Again, I can see the distended bowel loops. I'm going downwards, and I can see the collapsed sigmoid and the colon. However, I have made note that there is fluid in the pelvis as well. So I will call up the surgeon on call again and tell him that this is a cecal volvulus and needs immediate surgical intervention for the management.
Why the cecal volvulus need immediate surgical intervention?
Because it is going to, first of all, it has twisted on its pole. So there can be vascular compromise in this patient. If left untreated, it would lead to necrosis and gangrene, and would actually affect the bowel loops as well retrogradely. So this is a crush injury, 50-year-old male. Okay, so this is a patient of crush injury, RTA, and I have been given the axial contrast enhanced abdomen arterial phase. I can see that there is free fluid. I'm carefully looking at the arteries, and I felt that there is a sort of in one part of the liver parenchyma in the steer aspect, whether there was extravasation. I'm not really sure if I can see that part again. Yes, please. Thank you. So yes, there seems to be sort of blush in the segment 5-6 of the liver. So I will be a bit concerned, and of course
you can scroll.
Yes. Okay. Yeah. So I'm talking about this area. I'm not happy with this blush area, but however, I do understand that this is arterial phase, and I should look at the portovenous phase as well. I do not see,
look at the portovenous.
Okay. So with the portovenous phase, first of all, I can see this extensive hypodensity in the segment 6 of the liver, and I can see that the suspected blush of contrast, which I saw in the arterial phase, has actually increased in intensity. So this patient has a vascular injury within the intrahepatic arterial branches, which is also leading to the infarct of the affected segment. I will just have a quick look at the rest of the liver parenchyma as well. So I think the main finding, and maybe there is a small hypodense area, but I would consider it as a hepatic cyst. So in conclusion, this patient of crush injury has free fluid around the liver and the spleen, which is high density, hence hemorrhagic free fluid. I can see that there is a blush of contrast in the segment 6, which has increased from arterial to the portovenous phase with hepatic, I should call it laceration. This needs, I would immediately pick up the phone, tell the surgeon on call that this patient has this blushing of contrast, and this needs surgical intervention to surgically correct this.
So the surgeon is asking you, can you please help, because is there anyone else in your department to help?
Yes. Actually, I should also call the interventional radiologist, because this is amenable to be to have an angiography and to be embolized by the interventional radiologist as well. But of course, the surgeon has to be on the standby. This patient has an extensive liver. Yeah. So this is the angiographic phases, and I can see that there is a blush of contrast, with actually the contrast moving, going beyond the confines of the liver, and hence that explains the hemorrhagic ascites, which I was seeing. Can I take the other phase as well?
Yeah.
Okay, so there is another sequence provided, and this is post coiling embolization by the interventional radiologist, and we can see that that blush of contrast and this blood flowing out of the liver hepatic parenchyma has stopped, hence indicating that this was a successful embolization by the interventional radiologist.
Okay.
So this is 80-year-old male, day 4 post-CABG in ICU, distended and tense abdomen. Okay, so this is a elderly patient who is in ICU 4 days post-CABG. I can see that there is sternotomy sutures, but I can also see that there is a sort of distended small and large bowel loops. And I'm a bit concerned about a sort of linear thread-like hyperdensity overlying the left side of the abdomen, with actually two linear
they are external. They are external.
Okay.
Lights. External.
So they are external. I can see that there are two images provided, because in my provisional practice, I would also look at the frontal X-ray of the abdomen, which includes the pelvis as well, to be just show that there is no bowel loops seen overlying the hernia.
Okay.
This is day 4 post-cabbage. Yes, and I can see that there is bowel loop overlying the left inguinal region, which tells me that this is a case of left inguinal hernia, which has now become symptomatic and caused mechanical obstruction, leading to the symptoms of obstruction in this patient. I would inform the ICU as well as the surgeon on call regarding this finding for the surgical management of this patient.
Okay, so this is the CT. They did the CT. You are controlling. Yeah.
Yes. Okay. So I have now been provided with the. Let me take it up with the contrast enhanced axial CT abdomen. Sorry. I don't know why my mouse moves paradoxically, it seems. Okay. So going craniocaudally, I can see bilateral pleural effusion. I'm scrolling down. So this is a patient in whom I saw dilated bowel loops along with left inguinal hernia on the X-ray. So I can again see that there are dilated bowel loops. I'm also trying to keep the vessels in my profile to see if there is any thrombus or embolus in the arteries or veins. Up till now, I haven't been able to see any. I just saw in one of the bowel loops few air foci, but they are not in the antidependent part. But still, if they're in antidependent part, I'll be more suspicious for nematosis coli or nematosis intestinalis. But still, and yes, I can see that there is a bowel loop within the left inguinal hernia. I'll just scroll back to see if this is the small or the large bowel loop.
Yeah, is it a femoral or inguinal hernia?
Okay, okay. So first of all, this is actually a large bowel, which is herniating. Now I'm trying to see if this is femoral or the inguinal. I can see that the femoral vessels are on the lateral aspect. And they are not compressed. They are displaced only. I think this is direct inguinal hernia.
Okay.
This is. I have left the remote.
Yeah, thank you.
My 15 minutes are up, Dr. Saneej.
Over?
Okay. Yeah, they are over.
Okay. You can finish this.
Okay, so this is the T2 fat-sat MRI abdomen. And I can see that the liver has decreased intensity as compared to the spleen. I am also looking at the pancreas to compare the intensity of the pancreas. It does not look as decreased density as the liver. However, spleen is not involved. This is decreased intensity of the liver. So I would go with T1 in and out phase as well to see if there is any dropout of signal or not. This is still decreased intensity. I don't see any out of phase, but I would keep primary hemochromatosis as my possibility. And in these cases, the pancreas and the myocardium can also be involved. I would discuss with the clinician whether this is a known case or otherwise this patient can be now managed in the GI and hematology for management.
Okay, so your time is over, right?
Yes, my time is over.
Yeah, this is actually a primary hemochromatosis where you can see the hypointense, diffusely hypointense liver.
Yes.
And the spleen is not involved, the pancreas is not involved. So usually the primary hemochromatosis is genetical or hereditary.
Yes.
And the secondary hemochromatosis is usually due to repeated blood transfusion or something like that. And actually, in the secondary hemochromatosis, the distribution of iron will be in both reticuloendothelial system and non-reticuloendothelial system tissues and all. So here in the primary, as you told, you are looking at the pancreas, you are looking at the spleen, and the approach was good. It's fine. And this one, so whenever we see an abdomen with a distended bowel loop and signs of obstruction, so we have to find out the cause of the obstruction in that same film in an examination, especially in FRCR. So when the inguinal regions are not provided, as you told, you have to say, like in my normal practice, I'll usually include the inguinal region to look for. So then you found out that there is a bowel loop that is going below that obturator foramen level, and you are suspecting an inguinal hernia. So here also you are correctly looking for any complications like pneumoperitoneum, any pneumatosis and all. And this is not compressing the femoral vein. The femoral vein is very clearly seen. That's not being compressed. And that is going medial to that pubic tubercle. So that is going towards that scrotum level and all. So it's typically an inguinal hernia. And without any pneumatosis or any bowel perforation. So you will inform to the surgeon it's a surgical emergency. And in the crush injury, there is hemoperitoneum, that is dense fluid around the liver, around the spleen and all, and you are looking for any bleeding site. In a crush injury, you are looking for any liver injury. So you can see a liver laceration, very large liver laceration, that is causing some vessel injury, and you are suspecting a vessel injury here itself, and you correctly checked the delayed images, and there is a arterial injury. So you just call the surgeon and told that they need a surgery, but you have to offer that you have to tell him that we have interventional radiologists in your department, they can also help you.
Yes.
So without prompting, you have to tell like we can also help you. Anyway, this patient needs surgery. Before going to surgery, you have to tackle that bleeding vessel. Otherwise, the patient will go into hypovolemic shock and all.
Yes.
So here they correctly identified the bleeding point, and selectively or super selectively they have embolized it. Okay.
Yes.
Then 2 days of abdominal pain on examination, tender across lower abdomen with vague fullness. This one you did nicely. The typical description of a cecal volvulus with host tray and pointing towards the right lower quadrant, and the dilatation of dilated small bowel loops, and the large bowel loops are collapsed. So your description was good, and you're also looking for the complications in the CT, and your description was fine. And you correctly referred this to surgeon that it's a surgical emergency. But in this simple case, actually, they are looking for your approach, like it's a acute edematous pancreatitis, interstitial or pancreatitis without any necrosis. So they were looking for how you approach this case, like you are correctly looking at the edema, correctly looking at the arteries in the arterial phase, looking for any aneurysm, looking for any collection, looking for any necrosis, and other complications. So you have to say all the findings that you look normally in a pancreatitis case. Sometimes there may be an aneurysm, but in this case there is no aneurysm. And sometimes they'll give you another case after 1 week. Then you have to tell like it's an acute peripancreatic fluid collection, not a pseudocyst, because pseudocyst usually after 4 weeks, and it will be like. And if there is any necrosis, then you have to tell like it's an acute necrotic collection.
Yes.
So this one, your approach was good. Like you are looking for a mass that is causing the obstruction, but there is some irregular bleeding, like dilatation of the intrahepatic biliary ducts, and there was no central enhancement.
Yes.
So you correctly ask for the history of ulcerative colitis, then it is nothing else like primary sclerosing cholangitis. So this was your first case, I think.
Yes, this was my first case. Yes.
Thank you.
Thank you very much, Dr. Saneej. Thank you, everyone. Let's hope the day comes soon, Dr. Saneej. Let's hope so. Thank you, everyone, for attending. Dr. Saneej, if you want to give any parting remarks, otherwise we can end our session today.
Yeah, actually, everyone was good. Just like as I told you, we have to tell all the findings our own without waiting for the prompting, and we have to finish it with management. Like diagnose also, we should not stop at the findings. We have to tell the diagnosis differential, and if you are seeing the differential, you have to tell how to differentiate and what is the next management, and stop it with management. So these are all sessions. We can make all mistakes here so that we won't repeat the mistakes in the real exam. So it was good. It was a nice session.
Okay, thank you so much, Dr. Saneej. Thank you, everyone. Have a great day, great night, wherever you are. Bye-bye.
Thank you.